On behalf of Continental Hospital Critical Care Team, I welcome you all to this online webinar session of newer strategies of ventilator-associated pneumonia. So you all know that ventilator-associated pneumonia is associated with increased mortality, increased length of stay in the hospital, and increased length of stay on the ventilator also, and burden on the patients in terms of financial cost also. And we also know that use of VAP bundles in the ICUs will reduce the incidence of VAP to a large extent. And to know about the newer strategies to prevent the ventilator-associated pneumonia, we have our esteemed panelist, Dr. Moin and Dr. Santhosh from our hospital. So we welcome you, ma'am.
Hi, everybody.
Hi.
Thank you for having me here.
So let us welcome Dr. Moin, who is currently working as a consultant infectious disease specialist in National University Hospital, Singapore. And she is also a deputy director of Advanced ID Network. And she is a honorary research fellow in Harvard University. And she has many publications, multinational studies which are done, which are landmark publications like Regard VAP study and Akan High study and all. She also has around 35 publications in her name, and she has many awards into her account. Like for example, she like Asia Pacific Society Young Investigator Award and awards from the Oxford University, NICE Award, and Inspiratory Teacher Award from Singapore University. So I got an opportunity to meet her in one of the infectious disease conference, wherein she had given an excellent talk on ventilator-associated pneumonia. So we thought it will be very informative to welcome her to our webinar session on VAP. So that is the reason we have welcomed her. So initially, I will be explaining about the CDC definition of ventilator-associated pneumonia, followed by our newer strategies of ventilator-associated pneumonia, and then we'll have a question and answer session in the last. And we also have Dr. Santhosh, who is an infectious disease specialist in our hospital, Continental Hospital. We welcome both of you for this online webinar session.
Hello, everyone. Thank you.
Yeah. So coming to the definition of ventilator-associated pneumonia, CDC has given a surveillance definition. So in that, it initially defines any events on the ventilator with increase in the FiO2 requirement or the PEEP as ventilator-associated condition. So if there is an increase in the PEEP of more than 3 centimeter of water, or if there is an increase in the FiO2 of 20%, after the ventilated patient, after 48 hours of ventilation of the patient, then we can consider that as ventilator associated condition. And if that patient, so for this we need to know what is the daily minimum FiO2 or daily minimum PEEP. Suppose if the patient is on ventilator for more, the main criteria is the patient should be on ventilator for more than 2 days. After 2 days, if there is an increase in the requirement of PEEP and if there is an increase in the requirement of FiO2, on the daily minimum PEEP and FiO2, that is baseline period of more than 2 days, daily minimum PEEP, it should be maintained for at least 1 hour, both FiO2 and PEEP. So for example, daily minimum PEEP is the lowest possible PEEP, which is maintained for more than 1 hour. So in this, we can see 3 is the least PEEP which is there, but it is not for more than 1 hour. So that is the reason we can't consider as 3 as the daily minimum PEEP. We have to consider 4 as a daily minimum PEEP because it is more than 1 hour. On this, if there is an increase in more than 3 centimeter of PEEP, then we can consider it as ventilator associated condition. Likewise, for FiO2 also, the least FiO2 which is there for more than 1 hour in that 24 hours, then that is considered as a daily minimum FiO2. On that, if there is an increase of more than 0.2, then we can consider it is significant, and we can diagnose that as ventilator-associated condition. So suppose if the patient has fever spikes or hypothermia, rise in the WBC count of more than 12,000 or less than 4,000, addition of a new antimicrobial agent, so then we can consider it as infection-associated infection-related ventilator-associated condition. And so on after that, when we take a culture, if the cultures are positive, or if there is a purulent secretions with more than 25 neutrophils in that and less than 10 epithelial cells, then if the culture is growing with more than 10 to the power of 5 colony-forming unit in endotracheal aspirate, in more than 10 to the power of 4 in bowel fluid, and more than 10 to the power of 3 in protected breast samples, then we can consider it as possible ventilator-associated pneumonia. So this is how we diagnose ventilator-associated pneumonia. So initially with ventilator-associated condition and infection-related VAC, and then possible ventilator-associated pneumonia. So with this background, I will so let us go to our let us move on to our main talk on newer strategies for ventilator-associated pneumonia by Dr. Moin. Over to you, ma'am. You can
Thank you, Dr. Ramesh. I'm not able to share my screen at the moment because your screen is being shared.
Okay, I'll stop it now.
Thank you. Can everyone see my screen?
Yeah, we can see.
Great. Okay, so thank you everyone for attending this webinar. I understand it's dinner time over in India. So I'm Moin. I'm an infectious diseases consultant based at the National University Hospital, Singapore. I'm also the Deputy Director for the Advanced ID Network, which is a large clinical trial network at the National University of Singapore. And I'll be sharing with you today on newer strategies for VAP management. Yeah, so in this talk, I'll bring you through some latest papers from prevention to diagnosis to antibiotic treatment and adjunctive nebulized antibiotics. We'll focus on high-quality evidence published in high-impact journals, and this will include 2 randomized controlled trials, 3 meta-analyses, 1 secondary analysis of a randomized trial. Yeah, so firstly, the paper is focusing on prevention, and the name of this paper is Association Between Selective Decontamination of the Digestive Tract and In-Hospital Mortality in ICU Patients Receiving Mechanical Ventilation. And this paper was driven by the George Institute based at in Australia. So the rationale behind this type of decolonization strategy in ICU patients is that the healthy gut microbiome often safeguards against harmful pathogens. And we know from in vitro studies and observational studies in almost all critically ill patients, intestinal disruption due to butyrate-producing anaerobes leads to overgrowth of aerobic pathogens such as Enterobacterales and Candida. And that is why very often in ICUs, we do see invasive bloodstream infections caused by these 2 types of organisms. And therefore, there's been over 400 studies published to date looking at applying these oral paste and gastric suspensions with or without IV antibiotics to suppress Enterobacterales and Candida without suppressing the growth of anaerobes. And typically in the studies, PO or oral colistin, tobramycin, amphotericin nystatin are used, and sometimes with intravenous 3rd-generation cephalosporins and ciprofloxacins. And in this study, they included 32 trials, randomized controlled trials, including almost 25,000 participants. However, to note, 3 of the trials here highlighted in the red boxes, they contributed mostly to this meta-analysis, accounting for 75%. And all of these ICUs did not include patients or ICU units with endemic multi-drug resistant organisms, which is a little bit unlike in our Asian setting, and also including in India, where we see quite a lot of carbapenem-resistant organisms, VRE and Pseudomonas. Yeah, so going back to the earlier slide, you can see that amongst all these 32 studies, quite a number of them showed benefits. However, in the 3 major studies that accounted for a majority of the patients, they did not show a benefit in terms of mortality. However, if we were to focus on ventilator-associated pneumonia, which is our focus today, we do see that the effect size is far to the left, indicating that the meta-analysis result does favor intervention, and the effect size is quite respectable. And similarly, for ICU-acquired bacteremia, the intervention also was significant. And of course, the concern for us in our Asian setting is whether such a strategy will bring about increase in multi-drug resistance in the ICUs. However, if you look at all these different studies published since the 80s, there's no clear incidence or indication that the strategy brings about more resistant organisms. However, on the contrary, it actually shows that with STD, it reduces multi-drug resistant organisms in their ICUs. This is interesting, and I'm not sure if this is applicable to the Asian setting again, because in our Asian setting, a lot of our organisms will not be susceptible to those antibiotics being used. So that is the first paper on prevention. The second paper I'm going to discuss is on inhaled amikacin to prevent ventilator-associated pneumonia. And this is mostly done in 19 ICUs in France, again, in a high-income setting with very low endemic multi-drug resistance. And in this study, the main intervention was the nebulized amikacin delivered through the endotracheal tube, delivered for 3 days post 72 hours after intubation. And these patients must not have received any IV amikacin in the first 3 days. And in terms of the nebulization device, they use these ultrasonic frequencies to deliver amikacin deep into the lungs. As we know, the efficacy of such drugs or nebulized drugs is really dependent on the efficacy of these mesh or the technology that's being used to deliver the drug. So this is a fairly advanced technology. Yeah, so going to the baseline characteristics, we can see that the characteristics are fairly equally distributed amongst the 2 groups with amikacin and placebo. And the patients are about 60 years old, mostly males, with some kidney disturbances, and most of the patients were medical ICU admissions with infections and respiratory failure as the main indications for intubation. So these are typical ICU patients that we see in our Asian setting as well. And much to my personal surprise, actually, they managed to show a very significant improvement in terms of incidence to first ventilator-associated pneumonia episode. And you can see the difference here is fairly large at about 7% comparing amikacin to placebo. But however, even though the primary outcome here is protective, is favoring amikacin nebulization, but if we look at the secondary outcomes, which included median number of days of mechanical ventilation from randomization to day 28, median length of stay in ICU and hospitals, and most importantly, in terms of death, there were no differences. Now, this is counterintuitive because if amikacin can truly reduce incidence of VAP, we should expect death and length of stay and length of ventilation to reduce. However, the caveat here is that in this study, VAP was defined largely by positive quantitative bacterial cultures. And as we know, nebulized amikacin would naturally kill off a lot of bacteria in the throat, and therefore not detecting or having negative quantitative bacterial culture is what we would expect from such an intervention. So we can question in this NEJM study, did amikacin really successfully reduce VAP or not? Yeah, so perhaps you may think that these two studies that I've shared are not very applicable in the Indian setting, but however, I believe that there are still important lessons for us to learn. So firstly, we saw from the first study that manipulating microbiomes in ICU patients can potentially reduce VAP, bacteremia, as well as deaths. However, by manipulating the microbiome in the respiratory tract did not lead to such favorable outcomes. And why is that so? So there's actually been a recent large orbit even though it's an observational retrospective study, they did show that in this particular study here with the reference here that early administration of anaerobic antibiotics were associated with reduced survival and gut overgrowth of enterobacter relays. And this is very consistent with what we saw in the first meta-analysis where STD did reduce VAP and bacteremias. So coming back to our Asian setting, if we cannot use broad-spectrum antibiotics to protect the gut, and especially in terms of preserving the amount of anaerobes, can we use other methods to restore healthy gut microbiome to deliver similar effects for our ICU patients? So something to think about is something like perhaps next generation probiotics with anaerobic bacteria and or dietary supplements with metabolites such as butyrate that can help to restore the protective effect of our gut microbiome. It is something that's worth investigating. So the third paper I would like to discuss is on diagnosis. And this paper was published in Nature Communications. It's named Ventilator-Associated Pneumonia, Pathobiological Heterogeneity and Diagnostic Challenges. I thought this paper was fairly interesting as Dr. Ramesh highlighted earlier on the CDC definitions of VAP, VAE, and all that. There's a lot of different definitions out there. So this paper is interesting because it included 119 randomized controlled trials that's been published, and it found 38 different combinations of ventilator-associated pneumonia definitions. And you can see in this graph here, the inner circle here indicated the type of diagnostic criteria, which included a mix of imaging, usually chest X-rays, sorry about the slides, as well as blood test criteria, usually with full blood count, ventilator settings, as well as microbiological cultures. And when they applied all these different combinations of criteria to the same patient cohort, they found that as low as 4% to as high as 42% of the patients satisfied VAP criteria. So this just goes to show how varied these definitions are. And interestingly, in this paper, it broke down the sensitivity and specificity of different criteria to diagnose VAP, with the gold standard being histopathological analysis. And you can see here, unfortunately, with clinical examination, the specificity is only about 50%, which is really as good as flipping a coin. And in terms of radiological diagnosis, we can see chest X-ray is really poor in terms of specificity, but it is very sensitive. And CT findings and chest X-ray findings don't correlate very well. It may be promising to include lung ultrasound as the imaging modality, but all the studies were small and mainly observational. So hopefully we may get some randomized controlled trial data soon. And in terms of microbiology, generally they have higher sensitivity and specificity compared to just clinical examination alone. However, there's been large randomized controlled trials to show that there's no evidence that invasive bronchoscopy samples or even quantitative cultures can improve outcomes, important clinical outcomes like mortality, duration of ICU stay, antibiotic use. And also, as we know, even though a lot of emphasis has been placed on CPIS score, for example, it is not great in terms of sensitivity and specificity as well. And biomarkers like procalcitonin has slowly been phased out, especially if you look at the number of randomized controlled trials done around these such biomarkers. So what's the future of VAP diagnosis then? There's been increasing interest in AI or machine learning. There's been a fairly big kind of meta-analysis or reviews as well, looking at all these studies on machine learning. But again, the findings are that majority of these studies were quite small and retrospective. And also a lot of these studies excluded patients, and most of them were at high risk of bias. Another idea was to use immune markers, but such studies has been performed since 2010s. So it's been around for more than about 15 years now, but there hasn't been any headway in terms of especially the specificity of such markers in differentiating inflammation versus true infection. Okay, so moving on to the fourth paper, which is on antibiotic treatment. So this paper was based on an earlier conducted randomized controlled trial called the Idepasone trial. This trial was conducted mainly in France, looking at Pseudomonas aeruginosa VAPs and if antibiotic treatment duration can be reduced. As we know, there's always a concern about recurrence of Pseudomonas pneumonia when we reduce treatment. So in this paper, they made use of the same patient population, but compared monotherapy versus combination therapy to treat Pseudomonas. And if we read the current IDSA guideline from America and European guidelines, the recommendation is actually to use dual antibiotic therapy in high-risk patients defined by septic shock or risk of AMR or antimicrobial resistance. And in definitive antibiotics, to maintain dual therapy only in the most severe patients or multi-drug resistant infection patients. And these guidelines are only based on very old studies, for example, in vitro data, and this particular single cohort that was published in, again, France, with only 136 patients. So in this paper, in this secondary analysis of the earlier trial, they included quite a small sample size, 169 patients who receive appropriate empirical and definitive antibiotics. And again, this small sample size is because this particular trial had to terminate early because of slow enrollment. And the definition of combination therapy was beta-lactam with aminoglycoside plus minus fluoroquinolone. And you can see the baseline characteristics here are fairly well distributed other than arterial hypertension. So the reason why they included a p-value here is because even though it's a randomized controlled trial, when they compare monotherapy versus combination therapy, this is actually an observational cohort because these patients were not randomized between these two interventions. And surprisingly, if you look at the dotted line over here, this indicates combination therapy, and the solid line represents monotherapy. You can see that the survival probability is actually lower in combination therapy compared to monotherapy. This is, again, maybe counterintuitive, but if you understand that in observational studies, there's potential confounding such as disease severity that's not fully accounted for, then this phenomenon may occur because severely ill patients may be more likely to receive combination therapy compared to those receiving monotherapy. Yeah, so when we look at the number of days under mechanical ventilation and length of stay in intensive care units, we can see that the combination therapy, they had longer duration, and there is actually a significant difference between both. So this again indicates to us that there's the underlying disease severity that's not fully accounted for in this study. Yeah, so moving on to the fifth paper, which is on antibiotic duration. This is a REGARD VAP trial that I had the privilege to lead in about 40 ICUs across 3 countries. So this is a very pragmatic study. So we enrolled and screened and enrolled patients with VAP that's diagnosed with US CDC criteria. And we took consents from these patients and observed them for clinical response as defined by fever subsiding within for more than 48 hours and stable blood pressures. And then we randomized them to short duration and long duration. So for short duration, the duration can be as short as day 3 if culture is negative, and day 5 if culture is positive. And for the long duration is physician preference, but at least 8 days as recommended by the current IDSA and European guidelines. So this protocol uses a very simple set of criteria, do not need fancy biomarkers or any bronchoscopy, but just based on clinical markers, we can individualize duration to patient response. And the outcomes were day 60 mortality or pneumonia recurrence. And there were about 40 ICU in 6 hospitals from Nepal, Thailand, and Singapore that contributed to the study. So there were smaller hospitals such as in the Patan Hospital in Nepal, and big tertiary hospitals such as in Thailand and in Singapore. So the data hopefully is more generalizable across different income settings. And we screened 11,000 patients all throughout COVID. It was a huge achievement by all the investigators who contributed to this study. We enrolled patients from 2018 to 2022 and completed the study with 460 patients. And 434 of these patients were per protocol. And it was really, really challenging to bring the compliance or adherence to 94% actually, because as you can imagine, me being a foreigner going to countries like Nepal or Thailand, asking the ICU doctors treating the sickest patients to stop their antibiotics, it was really, really challenging. But I'm really, really grateful that the investigators were very, very supportive. So if we look at the baseline characteristics, again, they were equally distributed amongst both groups. So patients were about 60 years old. Majority of the patients were males. And most of the patients were transferred from other healthcare facilities because our participating centers were bigger hospitals with a lot of ICUs. And most of the patients were from surgical ICUs, and they had a fairly long duration of intubation before developing VAP at about 14 days. And the commonest reason for intubation were neurological failure and respiratory failure, as well as sepsis. And you can see that the mean SOFA score is about 6 across the groups, and the patients were fairly tachycardic. And the SpO2 FiO2 ratio at randomization was about 250 across both groups. And what we see in terms of the bacteria for the index episodes of VAP, vast majority of the episodes were accounted for by gram-negative bacteria, and 1 in 3, 1 in 4 episodes were caused by carbapenem-resistant gram-negatives, mainly by Acinetobacter, Pseudomonas, Cynomolgus. And in terms of the success of the interventions, we can see that the purple line here represents short strategy, and orange line here represents the standard of care. And in the short strategy, we were able to reduce duration by to about 6 days. And to note here, this is individualized treatment duration. So you see a variety of durations here, but the median was 6 days. And in standard of care, the median was 14 days, and you can see quite a number of patients went on to have 60 days of continuous antibiotics. And when we look at the primary outcome, there was no difference in terms of 60-day mortality or pneumonia recurrence. And to account for baseline differences in characteristics, baseline characteristics, as well as non-compliance in the protocol, in both intention to treat and per protocol analysis, there were no difference and met the non-inferiority margin of 12%. And in terms of the secondary outcomes, just by reducing the duration of therapy for VAP, we managed to reduce the total number of days of antibiotics exposure during admission, but the shortened duration did not increase the length of ventilation, readmission to the ICU, and stay in the hospital in general. So it's a fairly safe intervention to take for our patients. So what we learned from the REGARD VAP trial is that individualized antibiotic duration for VAP based on clinical response is non-inferior to standard of care. And this is the first study of its kind to just use clinical response to determine antibiotic duration in high-stake populations, predominantly from low-middle income settings. And the criteria, stopping criteria, simple and reproducible, can even be adopted by pharmacists, nurses, and traditionally non-prescribing clinicians. And there was no increase in recurrence when we look at the subgroup analysis of non-fermenting gram-negative bacteria. And hopefully this study is perceived to be generalizable given the diverse resource settings. And the last paper I would like to go through today is on nebulized antibiotics. So nebulized colistin is a very commonly used nebulized antibiotics in our ICU setting. And this is a recent meta-analysis published earlier this year. And this included randomized controlled trials, as well as observational studies with a control group focusing on adult patients that received both IV and nebulized antibiotic. And you can see here the number of patients included in all the studies were fairly small. The biggest being the first study at about 140 patients in general. And you can see the device here are very varied as well. So a combination of vibrating plate nebulizers, jet nebulizers, so on and so forth. And you can see in terms of clinical response, the meta-analysis did not show any difference between the nebulized plus IV antibiotics, even though the trend was towards favoring nebulized antibiotics in combination with IV. But again, when we look at just microbiological eradication, nebulized antibiotics tended to fare better, which is not surprising to us because it just shows that antibiotics were working on the bacteria in the trachea. So I would say in terms of nebulized antibiotics for our VAP patients, it remains an unanswered question. Most of the study designs were fairly heterogeneous in terms of drug dose and devices. The trials were conducted with very small sample sizes. But however, it remains a very important question because it can potentially reduce antibiotic exposure and therefore antimicrobial resistance in our ICUs. So this is the last slide for my 6 studies that I'm highlighting today. So what we have learned through these 6 papers is that firstly, gut microbiome likely plays a very important role for VAP development. And although we cannot use broad spectrum antibiotics in a wide population of patients in our Asian setting, we can consider manipulating this microbiome to prevent infections. The second point is that the diagnosis of VAP remains difficult. And while waiting for the next generation diagnostics, there's a need for more pragmatic approach for antibiotic stewardship. And that leads to the REGARD VAP trial, and where we highlighted that individualized antibiotic duration is non-inferior to longer duration. And we need larger randomized trials to guide what antibiotics we should be using for multi-drug resistant gram-negative VAPs. And in my last couple of slides, I just want to highlight the Advanced ID network that I'm co-leading with Professor David Patterson in Singapore. And we are based at the Saw Swee Hock School of Public Health at NUS. And what we focus on mainly is antimicrobial resistance, which is now known to be the 3rd cause of death in terms of global disease burden in 2019, and that way surpassed HIV as well as malaria. And this trend tends to go up over the next decade or so because global antibiotic consumption is largely driven by Asia and low middle income setting and not the high income setting. And so Advanced ID came about, we set this up about 2.5 years ago. And today, this is the only warm clinical trial network for infectious diseases globally. What I mean by warm is that we have ongoing studies that involves over 100 hospitals that's mainly based in Asia. And we spend a lot of our time and energy doing capacity building work. And you can see here, we've done plenty of site visits. I'm personally traveling all the time, David as well, understanding what the sites situations are, their laboratory capacity, what kind of patients, what kind of infectious diseases are affecting each country. So you can see here in Vietnam, in China, Thailand, over here is in Sri Lanka, Malaysia. the Philippines and Nepal over here. Yeah, so we try to sort of obtain a minimum standard for clinical trial capacity across our study sites by providing active study collaborations through protocol standardization. And of course, when we come together, patient enrollment is faster and we are able to share our data and results efficiently. So our overall strategy is we do a surveillance study, which I'll share with you, called ACON-HAI. And currently, we have planned several randomized controlled trials, including on diagnostics. So reducing microbiology testing time from, typically 3 to 5 days to as short as a couple of hours using PCR platform. We are also doing infection prevention control trials, as well as antibiotic treatment trials, both post-marketing trials and phase 2 trials. And just 2 slides or 2 or 3 slides on the ACON-HAI study. So this study is ongoing and we are enrolling at about 120 to 150 patients every single week. And so you can see over here in the map, we can, with such detailed data from each of the country obtained in Asia, we can easily see what's the disease burden across Asia in terms of infection syndromes, the bacteria types, as well as resistance patterns. As you can see here, in terms of each syndrome, VAP, bloodstream infections, and across the various organisms, we can see Acinetobacter is the predominant organism in terms of carbapenem resistance over here. And we can also see what are the antibiotics that's being used across the region in terms of empirical antibiotics here on the left and definitive antibiotics on the right. And monotherapy on polymyxin, even though it's not recommended in all international guidelines, is still the standard of care in most Asian settings. And we have also developed a dashboard, such as here, where we can see every site's enrollment rates, infection syndromes, what antibiotics they are prescribing, as well as antibiotic susceptibility patterns for the key WHO organisms, as well as offering them a time trend to facilitate local antibiotic stewardship and infection prevention control strategies. Yeah, I think I've gone way over time. Thank you very much for your attention. And I'll welcome any questions.
Thank you, Dr. Moy. It was an extensive discussion on the evidence of reducing the antibiotic duration with respect to REGARD, VAP trial, and ACON-HAI study, which is not accessible for the other audience and all. Apart from this, you spoke about that intestinal microbiota. Like how we can modify, how we can alter the intestinal microbiota so that we can reduce the ventilator-associated pneumonia.
Yeah, so there's various ways. So the studies that I have discussed mainly included using antibiotics to kill off the harmful bacteria, including Candida and Enterobacteriales, so as to allow anaerobes to grow. That strategy is not really applicable for us because we are worried about polymyxin resistance, for example, aminoglycoside resistance, which are already prevalent in our ICUs. And therefore, perhaps there's a need for probiotics or other ways of manipulating our gut microbiome by instilling more anaerobes in our gut, for example. But all these are at test tube stage or in vitro stage. There hasn't been any randomized controlled trials to see the clinical impact of these interventions. And these are important interventions and we should really look at them with time. Yeah.
Improving the anaerobes will reduce the incidence of VAP. That's what you mean to tell them.
That's right. Yeah, there's been good retrospective studies, observational studies, as well as the SCD randomized controlled trials that indicate this. Yeah.
So apart from that, regarding the oral care, which has a major role in prevention of ventilator-associated pneumonia, previously the recommendation was oral care with chlorhexidine solution, chlorhexidine mouthwash and all. Now it has changed to oral care with toothbrush, which is more evidence-based and which is having more efficient according to our ASID recent 2024 guidelines. So what is the difference between those two and why that has changed? Any insight on that?
Unfortunately, I'm not well read in this aspect, but from what we can gather is through brushing, you can remove plaques, and plaques are usually biofilms and big reservoirs of such bacteria. So in general, it's just about reducing the load of pathogenic bacteria in the respiratory tract. Yeah.
So in one of your study, you have studied about the carbapenem resistant Enterobacteriaceae in the hospitalized patient. After treatment, when they go home also, it was carried as a carriage. It was followed up with in one of your studies in terms of stool biofire and all. What was the average duration of antibiotic like CP carriage, carbapenems producing Enterobacteriaceae carriage in hospitalized patients after they get infected and after
Yeah,
they get discharged from the hospital?
Yeah, that's a really great question. We were very interested in that. So therefore, we followed patients who were discharged with carbapenem-resistant Enterobacteriales carriage in the gut and see if they transmitted that to their family members. And we saw through following them up over time, some family members did end up carrying carbapenem-resistant Enterobacteriales, but their carriage tended to be very, very intermittent for a very short period of time. And even for those hospitalized patients who receive a lot of antibiotics, their carriage tended to be just about 9 months or so. So therefore, that paper helped us to come up with the recommendation that isolation of such patients perhaps can be about a year or so before testing them again to see if they are already decolonized. I had this conversation with some ID physicians in CMC Vellore as well to see if there's been community-acquired carbapenem-resistant Enterobacteriales infections. And interestingly, they said they haven't seen much as well, which is consistent with what we've seen in Singapore. So hopefully carbapenem resistance is not as prevalent as ESBLs in the community. But we are continuing such studies in Singapore in terms of household community dwelling colonizers asymptomatically in the community. Yeah.
Santhosh, what is the role of closed suction in our ICU patients? What type of patients you will recommend that? Is there an evidence for that to prevent the ventilator-associated pneumonia?
Yes, sir. And regarding the closed and open suction, the concept of, if we see the closed suction and open suction, so in open suction, what we generally do is we pre-oxygenate and we detach the patient from ventilator, wear a sterile gloves, apply a kind of sterile catheter and suction it for a short period of time, and then we reconnect it to the ventilator. But what happens if we do an open suction? This is all theoretical concept. When the suction is performed, the secretions which contain this microbiota, there happens that it can lead to an environmental contamination or a patient contamination, or even this microbiota can be contaminated to the healthcare worker hands who is performing the suction. So that's where the idea of closed suction was brought in, where the whole circuit is completely closed. So this cross-contamination between the pathogens could be prevented. That's the whole idea where they actually brought in this concept of closed suction, basically. So whether this theoretical concept has been practically translated in the form of clinical trials and all, so we have at least good 3 or 4 RCTs and certain meta-analysis where they have looked this closed suction versus open suction. And if you see, the data is mixed, really. The data is not unidirectional supporting towards closed suction. So having said that, but the one other limiting factor which they could found is, at least with the closed suction, the cross pathogen transmission, because with the open suction, the cross pathogen transmission between the patient happened. That can be prevented with the closed suction. But if we see in overall terms of reducing the VAP rates, mortality, and ICU stay, the data is really mixed. So even the official bodies, that the CDC and the IDSA, right now, they are not they are not pro or they are not against for the recommendation. We need more solid or a concrete data to support this closed suction concept.
So regarding the cough pressuring devices, we have many electronic gadgets now to measure the cough pressure. Many are being marketed also. What is your take on that? How frequently if it is used, or whether there is any evidence for that? And then the subglottic suctioning also. So what is the evidence? What is the
For the subglottic suction, sir, at least like if you see conceptual wise, whenever we place an ET tube, the usual ciliary function, that the ciliary function of clearing the secretions will be lost when there is a tube in place. So that's where these secretions will be pooled in the subglottic area, and these secretions will, they downtrack to the tracheobronchial tree and they cause pneumonia. That's the idea of this pooling of secretions. So when they have assessed this subglottic continuous, suctioning of this subglottic secretions, the theoretical concept is whatever the secretions which will be pooled, they can be cleared and in turn the evap rates can be reduced. That's the idea behind the subglottic suction. So, and we have at least close to 20 or 25 RCTs and large meta-analysis where they have compared this subglottic suction as an additional measure compared to the usual measures reducing the VAP. And data was pointing towards reduction in VAP rate by almost 40 to 50% at least, where they were using the subglottic suction compared to the other measures. So in fact, even the official bodies, the CDC and IDSA, they say that we need to use the subglottic suction as an additional measure. If you see the CDC and IDSA recommendations for the VAP prevention, we have two categories of VAP bundle. One are the essential measures, that is the head end elevation, where we have a solid data that it would prevent it. And the second subset of recommendations are the additional recommendations. Additional in the sense, even if your ICU has a VAP rate, the ICU VAP rates are not pretty much controlled with the essential measures like head end elevation, decreased sedation, early physical conditioning and all. We can add this subglottic suction as an additional measure in our ICUs to reduce the VAP rates.
We have one question from our microbiologist, Dr. Bhavani, that how is the evidence for silver-coated endotracheal tube?
So for the silver-coated tube, sir, again, if you see the concept or the idea behind the silver-coated tubes versus normal tubes, normally our ET tube will act as a biofilm. The secretions are clogged to it or they'll act as a biofilm. And later, it's very difficult for the organisms to be cleared from the ET tube, which acts as a biofilm. That's where the concept of whether the silver-coated ET tubes would prevent this biofilm formation, and in turn, would it really reduce the VAP rates? That was the idea which was there. So even this idea was initially supported by one large trial where they initially showed that the VAP rates were low if we use the silver-coated ET tubes compared to the normal tubes. But if we go slightly deeper into that study, actually the VAP rates were more or less the same. It's just the colonizers in the ICUs have been prevented by the silver-coated ET tubes compared to the actual VAP rates. And later there's a lot of inflow data where the silver-coated ET tubes are currently not recommended. In turn, the silver-coated ET tubes, they won't form as an additional measure or even essential measure to prevent the VAP rate. But there's a new upcoming thing in this, coated kind of ET tubes. There's a concept called as BIP, the Bactec impregnated ET tubes. That's where they are calling it as BIP. So, basically it's a metal alloy kind of thing which is being coated on the ET tube. And this has been studied in 2 RCTs, although there were 2 short RCTs of 160 or 300 odd patients, where they were claiming that the VAP rates were significantly low. It was around lesser by 50% or even 60% in the VAP rates by these newer BIP tubes, that's the Bactec impregnated tubes. But really, to apply it as a general phenomenon, we really require a lot of data on it for the BIP concept. But definitely for the silver-coated ET tubes, it's right now it's a big no that we shouldn't use it as a VAP measure.
Dr. Mohin, you'll be doing many multinational studies and all. I think you'll be traveling most of the time. What is the process you follow for this multinational or multicentric trials? Like what is the protocol you follow from the beginning? Because it will take almost like 1 to 2 years or 3 years, I think, for these.
Yeah, to deliver a multinational study usually takes at least 5 to 7 years, unfortunately. Usually there would be an idea and protocol development. Usually we prefer to engage multi-stakeholders since the beginning. So we will convene an expert group from various important countries where disease burden is fairly high to design the study. And then we have to engage with the sites, engage with the local ethics boards and regulatory bodies, sometimes industry partners as well, to sponsor some of the drugs or devices that we need, and then training the sites and then actually collecting the data. Yeah, it's a lot of effort, and therefore we set up Advanced ID because it is an important gap. We can't afford to set up all these things whenever a new clinical question arises. So therefore we have a warm clinical network a clinical trial network that allows us to quickly adopt any protocols as soon as problems arise. For example, at the next pandemic, we can pivot our study sites to handle emergency questions. Yeah.
You about artificial intelligence in one of your slides. Are there any app or are there any website which will help us in simplifying that artificial intelligence which we can use for our audience?
Sorry, could you repeat that? Simplify the
Role of artificial intelligence in ventilator-associated pneumonia. You had
Yes.
mentioned in one of your slides. Is there
Yes.
any website or is there any app which will ease our process or will consolidate the data?
I wish there's a magic bullet, but unfortunately, there's really none. Yeah.
For probiotics, what is your take? Whether it should be used or not to be used?
At the moment, not to be used. Yeah, there's no any studies with inclination as for adult ICU patients. There was, of course, there's been some advancement in terms of probiotics in preventing neonatal sepsis. That there's a big RCT published out of India actually a couple of years ago. But in adult VAPs, there's no role as of yet. Yeah.
So I think we have very good evidence for early enteral nutrition. So how does it help in preventing ventilator-associated pneumonia?
Again,
Early
my
enteral nutrition. Early enteral nutrition is having very good evidence in preventing ventilator-associated pneumonia according to the evidence. So how does it help in preventing ventilator-associated pneumonia?
I'm not an expert in this area. I can only hazard a guess. It's got to do with keeping the motility in the gut that is helping motility in the respiratory tract as well, and also encouragement for the nutrients and encouragement maintenance of anaerobes in the gut. Yeah.
Santhosh, regarding post-pyloric feeding,
Right.
in what patients you want to use, and then is there any evidence for that?
So regarding the previous one, just an add-on point for the early enteric feeding. So what the concept of this early enteric feeding is early enteric feeding compared to the parenteral nutrition. If you use the early enteric feeding, your gut, the integrity is kind of maintained, and that prevents the bacterial translocation, and in turn the infection rates in the ICU. That's the whole concept with the enteric feeding. And coming to the second one, for the post-pyloric feeding. So post-pyloric, if either technique-wise, sir, it actually, you will require an endoscope to place a post-pyloric, tube to place it. And that again implies a lot of costs and manual labor involved in it. So post-pyloric feeding is not routinely indicated in our patients, but except there are few certain indications like severe gastroparesis or a gastric outlet obstruction, where we have the severe returns from the gastric contents, which in turn can lead to aspiration and increase the VAP rates. So probably in those settings, we can give a try. Again, it's an additional measure. It's not a straightforward recommendation. Probably in those patients, we can actually try if we have the access and there are no cost limitations and the labor limitations for that.
So my last question for both of you. Since regarding the VAP bundle, what we use regularly in all the ICUs everywhere, there are few evidences that there are few parts wherein we have very less evidence, and in few studies they recommend against use of gastric ulcer prophylaxis and all, and regarding DVT prophylaxis also. So do you think that we have to modify or update our WAB bundle?
Yeah, if I can take that question, Dr. Moin.
Yeah, please go ahead first.
Yeah, so probably my take with the gastric ulcer prophylaxis, there's no solid data to support the stress ulcer prophylaxis, at least to prevent the VAP rates. So probably I would say that part can be modified. So again, in terms of DVT prophylaxis, the data is really mixed. Because if we use a DVT prophylaxis, you're decreasing the rate of pulmonary embolism and in turn a ventilator-associated event rather than a ventilator-associated pneumonia. If you kind of prevent that ventilator-associated event, it in turn would affect with the mortality. So I won't see the DVT per se with the VAP rates, but I would see it as a whole pertaining to the mortality and the outcome of the patient.
Yeah, if there is no other question.
I have one question to Dr. Moin.
Sure.
Yeah, Dr. Moin, regarding the this regard VAP trial, do we have any subgroup analysis of carbapenem resistant, carbapenem resistant organisms causing VAP versus the shorter duration?
Yes, we did do subgroup analysis focusing on that, and there were no difference between the short strategy and standard of care as well.
Even in
Yeah.
the subgroup as well, okay.
Yeah.
Even with Acinetobacter,
That's right, yeah. So in the subgroup analysis, we look at non-fermenters, including Acinetobacter and Pseudomonas. We look at CREs, and we also looked at those patients enrolled during COVID and outside of COVID, and there were no differences. Yeah.
I think with this we came to the end of this session. I would extend my thank to Dr. Moin, Dr. Santhosh was our panelist, and who gave a lot of insight on ventilator-associated pneumonia prevention and the newer strategies also. I would also like to thank our IT team, our management, and our critical care team for their support. Thank you, ma'am.
Thank you very much for inviting me.
Thank you.